Okay, so it's my pleasure to introduce to the class Dr. Paul Harch. He is clinical professor, Department of Internal Medicine. He's the director of the LSU HSC Medical Center of Louisiana Hyperbaric Medicine. And his MD is from Johns Hopkins University School of Medicine. He has done a great service to humanity and bringing forward success, clinical success, with use of hyperbaric oxygen therapy. And he's had success with neurological injuries, traumatic brain injuries, drowning accident victims, and other medical conditions I'm sure he'll tell you all about. I invited him here to help fill in with Dr. Brownstein, since Dr. Brownstein was out of commission for this week. So without further ado, it is my sincere pleasure. Dr. Harch, take it away.
Thank you so much. Pleasure to be here. When we talked about this, you had asked me to make a presentation on precision dosing of hyperbaric oxygen therapy. And really what this is the practice of medicine. And understanding this, though, is going to necessitate a little bit about the history of hyperbaric medicine. And of course, we always have to start with this conflict of interest. I have a little consulting company. Of course, when you put this up, it means it disqualifies the scientific content of everything I say. And I say that tongue in cheek. But anyways, I have a little consulting company that's the other half of what I do. It's my practice, actually, in addition to the academic appointment. So I want to start off with just a couple key concepts. And the first one regarding dosing of hyperbaric oxygen therapy is to realize that all living organisms respond and are sensitive to both oxygen and atmospheric pressure changes along a continuum that are both independent and overlapping. And as it turns out, organisms respond to changes in oxygen and atmospheric pressure in either direction, meaning increases or decreases. And the second one is that the key to dosing hyperbaric oxygen is similar to the dosing of any other drug, with some distinctions, but it's dependent on identifying the targets of the treatment at the time of intervention. And it turns out, I'm going to show this with wounding, once you have a condition from its onset to wherever your point of intervention, the targets, the pathology, the pathophysiology change. And it turns out it responds to different doses of oxygen and pressure at different points in this disease process. So that ultimately the challenge is trying to deliver personalized medicine, which is finding the right dose of hyperbaric oxygen therapy for a given patient and their diagnosis at the right time in the disease process. So the key to understanding this is really understanding what is hyperbaric oxygen. And the answer to this question really has eluded the medical profession for roughly 347 years. And I set the timeline there at about 2008, when finally some information became available that had really been brewing for many, many years, but answered this question of really what is hyperbaric oxygen. And it's somewhat informed by the previous 347-year history, which I wanted to review real quickly. Hyperbaric medicine dates to 1662, and it was a British clergyman and physician. That's an interesting combination, but there are a number of these that are involved in hyperbaric medicine from its outset. And what he built was this bellows-like device that you see here, or operated by a bellows, but you sat in it and you could increase the pressure. And what he thought was elevated pressure should help with acute diseases and the lower pressures with more chronic conditions. And to this day, that is somewhat a truism. But from this time up until approximately 1960, all of hyperbaric medicine was with compressed air. And I want you to keep that in mind. It's a very important thing. And what happened after his initial bellows-driven chamber, over the next century or two, hyperbaric chambers sprang up in multiple European cities. And what they were doing was compressing people to up to 4 atmospheres pressure, which is equivalent to 100 feet of seawater pressure if you were scuba diving. Again, all with compressed air. By the 1830s, these became known as pressure baths, where you'd go and soak in a pressure environment. And that kind of gave a hint as to the amount of time people were spending in these. And if you look at that little picture there, from this time period, here they are, two guys sitting in there reading books. People would go in and they would stay for hours. Well, from 1830 to 1870, this rapidly spread throughout Europe. And what ended up happening, they treated a variety of different medical disorders. But also, 100 years earlier, the observation had been made after Priestley's discovery of oxygen in 1771 that simple normal baric oxygen was helpful in a dozen or so illnesses, from skin TB infections to asthma to paralytic conditions, leprosy even. And it should have been in the bottom corner there. Maybe on the next one, my little visual icons are blocking it. But this was the nature of the really famous drowned child's case that I published a few years ago, where we treated this child with normal baric oxygen to begin with. And on video, we were able to capture fairly dramatic neurological change with just a 45-minute administration of this, roughly 8 weeks after her drowning. And there she is, this little Eden Carlson, whose name is well known on the internet now. But what happened by 1885, curiously, hyperbaric oxygen started dying out in Europe. And some people thought it was due to the overselling of it, that it was used for so many conditions and claimed to have value. However, oxygen toxicity was discovered at the same time. And it was thought that that might have been part of the problem. But I think probably the other problem was decompression sickness. Decompression sickness had just been identified. And as I mentioned before, patients were going to 100 feet of seawater pressure in these chambers and staying for hours. If you look at the no decompression limits for a scuba dive, 100 feet of seawater, you're allowed 25 minutes from the time you leave the surface till the time you come up from 100 feet of seawater. If you stay beyond that time, you're into decompression obligation. And if you stay and don't decompress in water, you incur decompression sickness. And I think what happened is that there's been an age-old phenomenon, if you will. If some worked, more had to be better. And they treated at deeper and deeper pressures for longer times, and they ended up with people getting decompression sickness. But the point was, it eventually died out. And this was Paul Burt, who had discovered decompression sickness and also had a hand in oxygen toxicity. They were finding at the time, it's where the canary in the coal mine idea kind of came from, but larks and birds, of course, have a much higher metabolism. And with oxygen toxicity is reached much quicker. So with 100% O2, a lark can only live in that environment for a few minutes. So there was a fallow period until 1918, and most people don't realize this, but the formal introduction of hyperbaric medicine in the United States occurred in 1918 with the Spanish flu pandemic. And what happened was professor of anesthesiologist at University of Kansas City Medical School, Dr. Orville Cunningham, was in Colorado at Royal Gorge and musing about the increased mortality of Spanish flu at altitude. In other words, in the Rockies, which was really similar for cardiac conditions and other neurological ones, but especially with Spanish flu. And he mused that it had to be due to the low pressure and low oxygen environment. What would happen if they increased the pressure and oxygen? He raced back to Kansas City from Colorado, and they cobbled together this wheezy old chamber. And the first day it was operational, when they were to start the animal experiments, he was brought a dying Spanish flu patient. And in books and a journal article, it's described of how just with compressed air to all of about 10 PSI, which is roughly about 13 feet of seawater, excuse me, it's a little bit more, about 18 to 20 feet of seawater pressure, these patients pinked up and lived. They gave them one treatment a day for an hour over 5 days, and they were able to salvage the vast majority of these dying Spanish flu patients, which of course then has its implications for COVID infection. Well, what ended up happening, he eventually had this big steel ball 6-story hospital built in Cleveland, Ohio. And he treated a whole variety of conditions and made the observation that this had a peculiar effect of regenerating nerve fibers. Well, for various sundry reasons, but mostly the AMA's Bureau of Investigation, which got after him for not publishing his results, this was eventually scrapped and used as, metal for tanks and other armaments and so on. And so came to an end the era from roughly 1662 to the early 1930s, all of which was on compressed air. And if we go to 1887, there was a review article written by an Austrian physician on hyperbaric therapy, which had 300 references. Again, all of this without the use of supplemental oxygen. However, when you compress air, there's an embedded increase in the oxygen level. Well, finally, what happened? US Navy started introducing oxygen into decompression tables in the 30s, and by the 50s in the Netherlands, they were using it for gas gangrene, carbon monoxide, and blue baby operations. And now the modern era of hyperbaric medicine was born. So getting back to our question though, and it's still begging the question, what is hyperbaric oxygen? Well, the preliminary answer was historically, it was a disease-specific treatment. It was defined by the diseases it treated. And what diseases were those? Essentially any disease. High pressures for acute diseases, low pressure for chronic diseases, again, all with pressurized air. But in the last 61 years, it's become even more specific due to the use of oxygen. And so more specific, well, if you go to Russia, it's 70 diseases are treated, in China 49, 33 in Japan, but in the US just 15. And there was a critical article published in the Journal in 1987 identifying 132 uses of hyperbaric oxygen. So let's look at the US list for a minute. Here they are, the 13 indications: air or gas embolism, carbon monoxide poisoning, crush injury, decompression sickness, diabetic foot wounds, blood loss anemia, radiation damage, skin grafts and flaps that are compromised, thermal burns, central retinal artery occlusion, which is stroke of the eye, idiopathic sudden hearing loss, and then 4 of the necrotizing soft tissue infections, actually 15 indications. And of course, the medical profession, when you look at this, if you're not familiar with hyperbaric oxygen, everybody has the same quizzical look like, how does a compromised skin graft relate to a chronic bone infection or a thermal burn or decompression sickness? And this has been the Achilles heel of hyperbaric medicine. And the reality is they are linked by common pathophysiology. And so hyperbaric oxygen, in fact, is not so much a disease-specific treatment, although it's been defined that way. It's a non-specific treatment for disease pathophysiology. And in the US, why so few? Because animal and human literature was used at the time the FDA was grandfathering hyperbaric chambers in 78. And they went to the Hyperbaric Medical Society and said, what's this good for? And they gave them a list of indications, the clinical evidence of which was not strong. And the FDA literally rubber stamped it. And that's what we're left with here in the United States. Inadvertently, what all of these had in common, and all of the conditions that, almost all that hyperbaric's been used for historically, is not only the similar pathophysiology, which includes inflammation, but almost all of these are wounding conditions of one type or another. So if we go back and look at the hyperbaric list in the US, all of these are different types of wound conditions. Even exceptional blood loss anemia, which is essentially an ischemia or a hypoxic ischemic wound or injury, similar to stroke, but more systemic. Radiation tissue damage, clearly a wounding condition of tissue, compromised flaps and grafts. And the infectious ones, we're not used to thinking of infections as wounding conditions, but all of these involve destruction of tissue. And so they are, in effect, wound conditions. If we now go to those international lists I showed you earlier, all of these conditions, nearly all of them, except maybe the genetic conditions, are in fact wound conditions of one type or another, in which inflammation is a dominant form of pathophysiology. So how do we dose this? And to dose this, you have to understand wounds. if any of us here incur at this moment a wounded condition, i.e. you cut yourself, you fall, contused, get electrocuted, have a cardiac arrest, whatever the condition, there are some idiosyncratic differences between the type of injury, whether it's, let's say, ischemic, hypoxic, traumatic, mechanical, a chemical injury, electrical, whatever. But the second you have tissue damage, the inflammatory reaction takes over and it's stereotypic and it dominates the pathophysiology such that any wounding condition then runs a course. And I put up a few slides here just to show that wound healing goes through phases. You know, the early phases, inflammatory, then a granulation phase, and then eventually a remodeling and chronic phase. And of course, during each of these phases, there are different cell types that are prominent all the way through, you know, tissue repair, scarring, collagen remodeling, and so on. And with that, there's also different gene expression that takes place at different times and different physiology that is active even years out from wounding. In fact, if we look, for example, at simple wound strength, like a surgical wound, by 6 months, you achieve about 85% of final wound strength, but it continues on asymptotically for quite a period of time. In 1998, the NIH Consensus Conference on TBI, one of the main findings that came out of it was the timeline for saying that there is no further change in the brain after a traumatic brain injury was a year, was completely wrong. It was more like 7 to 10 years or longer. So in fact, wound healing goes on for quite a long period of time. Well, as I mentioned, hyperbaric oxygen has effects on acute and chronic pathophysiology, depending on the different point in the disease process. And you can look at these as effects on acute and chronic pathophysiology as well as pathology. And there have been, I just listed some of them here, but there's a whole bunch of them now that have been documented over the years. Effects on alpha toxin, cessation of production, clostridial bacterial stasis, reduction of edema. This has been shown now in every tissue and organ in the human body with hyperbaric oxygen. Effects on burn shock, survival, hemorrhagic shock, again, burn edema, enhancement of white blood cell mediated bacterial killing, effects on hypoxia, dissociation of carboxyhemoglobin, and effect on reperfusion injury, which is that return of blood flow after interruption, which, you know, you can think of as any operation where we tourniquet an extremity, cardiac arrest, transplants, tissue grafts, you name it. It is a common pathophysiology, and hyperbaric oxygen has been shown in dozens and dozens and dozens of articles, different organ systems, different models, to all have the same effect, which is inhibition. And then, of course, there are chronic effects, and almost all of these are trophic. So effects on fibroblast proliferation, bone remodeling, angiogenesis, new skin formation, changing the oxygen tissue capacitance of ischemic tissue, mobilizing bone marrow stem cells into the circulation, inhibiting inflammation, and there are now multiple review articles on that. So there are a lot of different effects there. And we now get to the question of, well, how can hyperbaric oxygen have such panoramic effects on disease pathophysiology? And what we have to do is look at it in terms of, there are three components to hyperbaric therapy, and I'll tell you how part of this came about in a minute. But we put someone in a chamber, you increase the pressure of oxygen, and you increase the pressure of all of the purportedly previously known inert gases, such as argon, helium, etc., which are in small amounts, but argon is about 0.9% of the atmosphere. All of these, it turns out, are bioactive. And it turns out also that all living organisms are sensitive to changes in barometric pressure and oxygen levels, as I mentioned at the very outset of this little talk. So the site, it turns out, of this level of sensitivity is at the core of our existence. It's at our DNA. And this gets to the question then of, if we're treating wounding conditions and we're healing these wounds, how do you heal wounds? Well, the dominant effect that's been demonstrated with hyperbaric oxygen is an effect on growth of new tissue. And how do you do that? You have to stimulate the cell to divide and multiply. And to do that, you've got to go through the nucleus and the DNA. And what has now been shown and that timeline I took you up to at 2008, is that the mechanism of action, one of the dominant mechanisms of action of hyperbaric oxygen, is DNA signaling. It's an effect on transcription or suppression or expression of our genes. And I'm going to take you to this. We're not going to go through this because it's a convoluted argument that nobody got at the time it was published by a group of plastic surgeons in St. Louis in 1997. They were looking at ischemic rabbit ear wounds. And what they would do is, at the base of the rabbit ear, they would divide the central artery, and distally, at the end of the rabbit ear, they would get this ischemic wound. And they put oxygen probes in there, and they started measuring PO2 under different conditions. And what they found was the ischemic tissue reacted in a certain way. But if you stimulated it daily with hyperbaric oxygen, its handling of oxygen changed, the entire physiology of it. And their argument was that this was changing it at a DNA level, and how the genes were expressing and affecting metabolism of oxygen. And like I said, it's kind of a convoluted argument. And the whole medical profession kind of looked at it, especially hyperbaric, and just yawned. But what happened is the conclusion was that hyperbaric oxygen was a DNA signaling agent, similar to just normal baric oxygen and growth factors. And what ended up happening subsequently over the next 11 years is that sporadic articles appeared in the basic science literature where they targeted individual genes or gene products. And this is just a little list of them, looking at platelet-derived growth factor receptor, platelet-derived growth factor receptor as well, intracellular adhesion molecule, vascular endothelial growth factor, hypoxia inducible factor 1 alpha, which we know is at the root of hypoxic signaling, but is also affected by hyperbaric oxygen, angiopoietin, a vascular hormone, mitochondrial DNA, the apoptotic genes are affected by it, basic fibroblastic growth factor, procollagen mRNA, heat shock proteins, antioxidant genes, and basic derived neurotrophic factor. And there are more. But what they were showing is that a hyperbaric oxygen exposure was somehow impacting genes. And then 2008, this seminal experiment, well, a series of them were done, and I'm going to show you two of them. But this one by Dr. Godman in Massachusetts, what she did was take human endothelial cells. And as we all know, the endothelium is really where the rubber meets the road in terms of disease pathophysiology in the human body. It's the microcirculation. And there are most reactive cells in the body. And that's what this experiment showed also and underscored. What she did was take human biopsy specimens, and they took normal endothelial cells from the microvasculature, and they gave this single dose in a Petri dish. If you recognize this, if you have ever seen much about hyperbaric oxygen, that is the standard clinical dose given for the majority of hyperbaric oxygen conditions, 2.4 atmospheres for 60 minutes. Actually, it's given for 90 to 120. And what they did was a mass gene array analysis of all 23 pairs of human chromosomes. And at the end of 24 hours, 8,101 of the 19,000 protein coding genes in our DNA were either up or down regulated significantly. And the largest clusters that were turned on were the anti-inflammatory and growth and repair hormone genes. And the most significant, or the largest clusters of the downregulated genes were the ones that were responsible for inflammation and for programmed cell death. If they gave another treatment at 24 hours, by 48, there was more gene expression, and the cells began forming microtubules in a Petri dish, i.e. the root of angiogenesis. The point was, we had vast effects with a mild, an increase in oxygen and pressure on human endothelial cells. And of course, it was always thought that it was due to that rise in oxygen level. And that pulse of oxygen was thought to act epigenetically. And so if we look at a kind of a schematic of a gene where we have enhancer proteins and then a whole bunch of other transcription factors that get involved, somehow hyperbaric oxygen was acting to affect this initiator segment of the gene, causing binding of the enhancer segment at least, and then transcription rolls like a ticker tape with RNA transcriptase. And another way of looking at this schematically is, here's our DNA coil, here are all the histone proteins on the inside. These reactive moieties that stick out are the ones that are sensitive to stress, environmental factors, alcohol, drugs, pesticides, chemicals, lifestyle, all of these things. And of course, when they are affected, methylated, acetylated, etc., conformation of the histones changes, electrical charge changes, and that initiator segment of the gene is then affected, and the gene is either locked down or read. And here's just another little schematic of that and how the histones are involved with that. So what we've got essentially is an epigenetic phenomenon that hyperbaric oxygen is causing. And the oxygen signal, as it turns out, to just understand this a little better, is caused by Henry's law, which is one of the universal gas laws. And what that universal gas law says is that the pressure of a gas interfacing with a liquid is proportional to the pressure of that gas. So if we double the pressure of the gas, 1 atmosphere absolute is what we're at sea level. 2 atmosphere doubling is the equivalent of 33 feet of seawater below the surface. We double the amount in solution. And so with oxygen, 98% of our hemoglobin saturated at room air at sea level, just a little whiff of oxygen, you're 100% saturated. The rest of it all goes into solution. And if we look at a cross section of an alveolus, here's the alveolus with oxygen and CO2. Oxygen ends up having to dissolve, cross the alveolar membrane into the interstitial fluid, and finally to the interfacing capillary, where it's dissolved in the liquid form, the plasma, and finally binds to hemoglobin such that as the blood passes over the alveolus, it's oxygenated. Well, what's the limit here? The limit's the pressure of oxygen. So at sea level, we can go from room air, 21%, to 100% by a non-rebreather mask, and we top out. But is that really the limit? No. When you get to the limit of Henry's law in the lung at atmospheric pressure, all you do is increase the pressure. And that's what we do with hyperbaric oxygen. So you get in an enclosed vessel, increase the pressure, and that additional amount is all now dissolved in the liquid portion. So if we look at 1 atmosphere sea level, and the typical limit of a hard shell hyperbaric chamber, 3 atmospheres, here is the pressure that's involved. Ooh, I'm sorry there. If we're breathing air, this is the amount of dissolved oxygen. The hemoglobin's 100% saturated. Here's the amount of dissolved oxygen when you're breathing pure oxygen at pressure. And this number is the key. That amount, 6 volumes percent, there's an additional 20 volumes percent bound to hemoglobin. That exceeds the extraction fraction of every vital organ in our body, such that you don't need hemoglobin to survive. Meaning at 3 atmospheres of pure O2, you can run your body on dissolved oxygen in plasma. And this was done in 1960s in the Netherlands, where they showed with pigs, they did an exchange transfusion with normal saline at 3 atmospheres of pressure in a chamber, and took the pigs down to a hematocrit of 0.4. So they essentially had slightly pink saline in their blood, and they were completely happy as pigs in a hyperbaric chamber at 3 atmospheres. They then re-exchanged transfusion, brought them out, and the pigs lived. The point is, we can use this, and as you give it and withdraw it, it is acting like a drug, such that hyperbaric oxygen is considered a drug by the FDA, and it acts like one in every way. And the basis of hyperbaric oxygen was thought to be the physiology and biology of intermittent hyperbaric hyperoxia. And of course, if we're going to talk about a drug, it has to obey all of the dosing principles. And in fact, it does, including overdose and toxicity, which is well known with hyperbaric oxygen. Well, the question always arises, how much rise in oxygen and how long do you have to stay there to get the effect? And is it the withdrawal that is the signal to the DNA and to our other physiologic targets? to induce these drug effects? And nobody has really answered that. But what I want to show you is with SPECT brain imaging and a discovery that we made back in the late 1980s looking at our divers, and that it may not need a whole lot of oxygen or pressure, that we in fact may be very sensitive to this. This is a veteran with traumatic brain injury, blast-induced traumatic brain injury. And I put him in the chamber and he could only tolerate it for 30 minutes. He became very claustrophobic and demanded to be taken out. I only got to 1.25 atmospheres of oxygen. This is a SPECT brain scan, sagittal views. So each one of the images, face would be here, back of the head, and we're looking from the left ear. And each of these numbers here are the average counts per pixel and the maximum numbers. And what I want to show you, I'm going to toggle back and forth between these quickly. This is after the one treatment, 3 hours later, he gets imaged. And what you're going to see is a change in this heterogeneous dark light pattern, this irregularity, to a more homogeneous pattern, which is normal. And with it, there's about a 8–10% average increase in blood flow. So here we go. Oh, goodness. I'm sorry. Here we go. Look at the heterogeneity. Try to focus on these lower ones here, where it's a little more evident. You'll see it on all of them, though. But here's after one treatment. Back to the original. After one hyperbaric treatment, the original, heterogeneous, smoother, more normal appearance. And with that, there was an overall change in blood flow to the brain. So this was a small amount of pressure and oxygen. And it's similar, the Godman article was a much greater amount. But what it showed us was the effects of oxygen at pressure. But it kind of also asked the question, how about the effect of hydrostatic or barometric pressure? And for the entire history of hyperbaric medicine, this has been ignored. If we look at this little graph, kind of busy, that is absolute pressure from absolute 0 to essentially 1,000 PSI. So this is outer space. And on the right-hand side here is above and below sea level. Here's the safe zone for human existence. As it turns out, hyperbaric therapy is operating in this very narrow pressure range here. And if we look at living organisms, as it turns out, we live at pressures to which we've been adapted. We look, for instance, at birds. Different species exist at different altitudes. And this is both an altitude issue and likely an oxygen issue, but it's similar to plant and livestock species. They seem to thrive at certain altitudes better than others. In the opposite direction, below the surface, we have both plant and animal species that only live at certain levels in the ocean, and they're adapted to that pressure environment. Well, we also know that if you decrease in pressure, expose an organism, in particular a plant, but we know this for humans, and the Nobel Prize was awarded for this with all of the information on hypoxia-inducible factor 1 alpha. But if we decrease pressure, there are gene expression effects that occur. NASA is the one who's done the most experiments on this. Trying to grow food in space, they have to do it in a low pressure environment. And what they've shown is that plant species respond to atmospheric pressure changes, just like human beings and animals do. And we also know that the increases in pressure in the opposite direction are bioactive. In fact, what's been shown with the plant species is that a change of just 0.25 atmospheres, which is nearly identical to what we have in a commercial airline cabin, affects the expression of hundreds of genes in this one plant. So if we look on the left-hand side here, these are all of the genes in black that are expressed under normal sea level atmospheric conditions. These are the ones under hypoxic conditions. So they're both the induced ones and repressed genes. You have a mix. And here are the ones in the hypobaric environment, showing that there's some overlap, but there are also distinct differences between genes that are activated by low pressure and those by low oxygen. And I'm really digging into a lot of basic science here, but I'm going to bring this to a clinical point here at the end. So what happened in 2008, I went to the FDA and I was asking for an investigational new drug exemption for the study we were doing, randomized trial on hyperbaric oxygen in persistent post-concussion syndrome that got published in March of 2020. And for the first time in the history of hyperbaric medicine, the hyperbaric oxygen INDs had been placed under the drug side of the FDA, used to be under the devices side. And when they looked at my application, they came back to me and they said, you know, this is the first time we've looked at hyperbaric medicine, but you're asking for our sanction of a single dose of hyperbaric therapy. We look at your therapy as a combination therapy of increased pressure and increased oxygen. You're putting someone in an enclosed environment, you're turning up the pressure and you're turning up the oxygen. And those two things, we don't know if either of them, neither of them, both of them, or what effect they may have. You got to prove that with different pressures and oxygen. And I thought they were crazy. I'd been in this field 26 years at that point. Not one conference, not one publication, nothing I had ever seen had ever talked about the effects of pressure, barometric pressure. Yet in fact, barometric pressure is a thermodynamic intensity parameter that is involved in every chemical reaction in the universe. And, you know, when the going gets tough, the tough go to the library. I went to the medical library and did a literature search, and what did I find? Since the 1940s, there were dozens of articles on the physiology and biology of pressure, including especially the micropressure range. And this one article here looked at pressures between 1 centimeter of water and 1.3 atmospheres, which is one of the pressures that's been used in hyperbaric medicine with air, and even in the previous hundreds of years. And I abstracted the results of this, and these were the results of these articles. You can look at the pressures here, 1.21 to 1.26 ATA, and effects on animal and human endothelial cells, platelets, causing elaboration of vasoactive substances, all of these things, growth factors, inflammatory mediators, and the effect beginning, you know, after just minutes of exposure, 1 minute to even 3 minutes at these very low pressures, there was a physiologic change. And, you know, it kind of made sense. I mean, why wouldn't living organisms have the ability to respond to increases in atmospheric pressure with gene expression? Well, they do. All we got to do is think about migration of animals with temperature, with the seasons, and so on. But here was an experiment that looked at this a little more closely, looking at neurons, which aren't as reactive as endothelial cells. But what they did was take rat cortical neurons and they exposed them to a variety of conditions: normal baric air, 100% normal baric oxygen, or hyperbaric air at 2, 4, and 6 atmospheres, or hyperbaric oxygen at 2, 4, and 6 atmospheres. And what they found was, regardless of all of those different conditions, there were 183 genes that were up or down regulated. 17 were common to all exposures, but more genes were altered with exposure to pressurized air than oxygen. And here were their numbers. So 2, 4, 6 atmospheres of air, 100% 1 atmosphere oxygen, 2, 4, and 6 atmospheres. And the genes that are upregulated were identical in number, but the numbers that were suppressed were different. And the higher we went in pressure, the less genes were suppressed. And when we look at this with a Venn diagram, look at the air pressure genes, we have genes that are independent to a particular pressure, overlapping with one other dose pressure, and common to all 3 of them. And this was true with the oxygen ones, but much less genes were involved. It turns out that the pressure was seen to downregulate genes, and the oxygen tended to upregulate them. So now this is adding a whole new degree of complexity to what we thought was stupidly simple hyperbaric oxygen. Shove someone in a chamber and turn up the oxygen. What we're doing is playing a symphony with people's genome in the regions of wounds in their body. And so, you know, what was also found was if we look back at these numbers, take a look at what happens at 2 atmospheres of air. 2 atmospheres of air, we have 163 genes affected. 2 atmospheres of oxygen is 2 atmospheres of pressure plus the oxygen. And yet you would think the pressure genes would still be on or suppressed. They weren't. What it meant was we not only had independent and overlapping, but we had interactive effects where pressure was affecting the oxygen exposure genes, which means this became an even more complicated issue, that dose may be dependent on many different factors here, all the gases involved, which then leads me back to the question I started with. What is hyperbaric oxygen? It's the use of greater than atmospheric pressure, oxygen, and really these inert gases as drugs to treat basic disease pathophysiology, and hence the diseases that contain them. So if we go now to, dosing hyperbaric medicine, how do you do this? Well, we have to look at what is the practice of medicine. If we look at the Hippocratic Oath was originally written as, I will prescribe regimen for my patient while doing no harm, which means treating you and your disease idiosyncratically, as opposed to one size fits all. So anyone going into their doctor's office, seeing their physician for whatever problem, you're treated as an individual. And the problem with hyperbaric medicine in the United States and all of these wounding conditions is that with a lack of understanding of what we were doing and the science of this, the treatment and dosing relied on historical precedent. Oh, I treated someone with this condition at this dose, it worked. Okay, I'll do the same. And over time, you, by Bayesian analysis, really, and statistics, generate what became somewhat rigid protocols, unlike no other specialty in medicine or no other practice, except maybe clinical trials where you deliver a rigid protocol to everybody, with the exception of now adaptive trial design. If you look at the summarization of the recommendations for hyperbaric oxygen, which is the Undersea Hyperbaric Medical Society committee report, nearly all of these indications are for 2 to 3 atmospheres of pure oxygen in a very narrow range. And if you look at most of those, it's between 2 to 2.4 atmospheres. So it's become a specialty that oddly was driven by rigid protocols. But again, what's the practice of medicine? Every human being is, by our DNA, idiosyncratic and individual. And when you now apply a disease process to an idiosyncratic individual, we've got idiosyncratic on idiosyncratic, or idiosyncratic squared. Each person is their own entity. And so personalized medicine and the dosing of hyperbarics becomes finding the right dose of hyperbaric oxygen for the given patient and their disease at the time in the disease process, which finally leads me to what I wanted to talk about, which was precision dosing. And I'm going to take you to the first statement that one of my mentors made to me in 1990 when I called him up, and I had this diver in extreme condition, demented, in the process of threatening to commit a whole series of homicides. And I asked him, well, how would you treat this guy, or could you, or is he treatable? And he said, our biggest problem in hyperbaric medicine is we just don't know the dose. And he continued to say that to me for the remaining 17 years of his life. And he was exactly right. But what we decided to do was investigate how to dose hyperbaric therapy. So from 89 to 99, we very rigidly looked at nearly 200 patients, neurological patients, who got referred or self-referred for a chronic neurological problem. And what we did was evaluate them with a brain blood flow scan, SPECT. Following day, put them in a chamber at a given dose, and then repeated the SPECT scan 3 to 4 hours later, which is what I showed you earlier. And I want to show you another example here with an 8-year-old autistic boy. And these are, again, sagittal views. And you can see the color map here is highest brain blood flow. It's back in the cerebellum here, this bright white yellow. It goes down through yellow to orange, purple, blues, 2 different blue shades, and finally black. Every color change is about a 20% reduction in blood flow. Here is after 1 hyperbaric treatment. A fairly dramatic change. I mean, the janitor can read this film. You have that smoothing, more normalization type of effect, and overall improvement in flow. It turns out when we saw that, after that single treatment, I could sit and guarantee to the patient, irrespective of their diagnosis and brain pathology, that they would improve. That was a predictor of improvement neurocognitively with repetitive hyperbaric oxygen at that dose. If we didn't see that change, it was about a 50-50 shot. Half the patients would improve, and it just meant the scan wasn't, the negative wasn't predictable or predictive, and half didn't improve. But what happened was, if I wanted to test another dose, let's say I had a negative scan afterwards, I had to repeat the SPECT for each dose tested. And insurance reimbursement used to be okay for that. But now it's darn near impossible. You can't do it anymore. It's an out-of-pocket expense. It's $2,500 per scan. It's prohibitive. The other problem was that second SPECT scan showed the delayed effect of what had happened in the chamber 3 hours before. I could never image the brain while under hyperbaric pressure and oxygen until now. And what I've done is adapt standard EEG with a wireless Bluetooth headset to get a standard, 1921 lead EEG in the chamber and take patients through a dosing profile. And what I'm able to do, these circles here are the different frequencies of current. So delta, theta, alpha, low beta, beta, high beta, gamma. And we are looking at the patient's brain from the top. So nose is up at the front. Here are the ears, back of the head. And it's the same for these circles here. And the brain is then squashed into a circle. And the colors are coded by standard deviations compared to normal. So left hemisphere, right hemisphere, and then the different lobes. And what happens is I can watch the brain live and look at changes that are occurring. I'm going to show you this in a minute. And here it is, for instance, after, or the other thing that you can do is you can look at 3-dimensional connectivity and 3-dimensional effects of the different frequencies of current in the brain live. Again, color coded by standard deviations compared to normal. So if we look at this live one recording, you see this is a 30 millisecond delay from what is in the brain to what is on the computer. But you see the electrical activity in the brain changing for all of these different frequencies. And this is done before going in the chamber. If we now look at this while in the chamber, and it's a little harder to appreciate on this, you have to really kind of study it. But what ends up happening is these change with different doses of hyperbaric therapy. You see this blue area crop up in there, the standard deviations change, and so on. And what you do is this is analyzed over a period of time recording and looking at for different doses. Here is now another segment, and look at the reduction in delta here, for instance. Remember how white this was across the whole inferior or superior part of the circle or the brain. And what's happened is the standard deviations also change with that. So this was a series of different doses that I was putting the patient through, and simultaneously also looking at the 3-dimensional changes, excuse me, let me do this right, as they rotate, and looking at connectivity, which are the lines on there. It doesn't reproduce so well for the computer, but you also see the flashing of the of the electrical frequency, the current, as it dips into a more normal range. The white is 3 standard deviations too much. And here again now is, oh, I'm sorry. Now with a dose of hyperbaric therapy, you see how the brain is changing on the right-hand side there. All of this, each recording comes back with an extensive amount of data. And what I do is look at this and look for the best effect and then target the dose. You can also look at connectivity maps and so on, and get some idea on where to start with dosing a patient. So that now what I'm doing is trying to dose this multi-component drug to an individual patient's disease and at the time of intervention in their disease. So if we can draw some conclusions from this, probably the most important thing is to realize that this treatment, which for 360 years has been really unexplained and misunderstood by the medical profession, is actually a dual component drug consisting of increased barometric pressure and increased oxygen, as well as increased pressure of, quote, inert drugs, that treats disease pathophysiology. And it's pathophysiology that is common to many, many conditions. It seems to have found benefit primarily in wounding conditions, which really is a vast array of medical conditions. And one of the primary mechanisms is widespread gene signaling, both suppression and expression of genes. Our goal, just like with the dosing of any drug or therapy, is trying to find the right dose for a person's disease at the time of intervention in their disease process. And for at least neurological diseases now, it seems that precision dosing may be at hand, at least with this therapy. Thank you. And that is